Good afternoon, everyone. This is a sponsored program, and so I would like to stick to the slides. My job has already been done mostly by our stalwarts this morning, so I don't have much to say in this regard. But still, I will continue. This is the disclaimer. And at the present time, as we have known that we have gradually shifted from the concept of migraine as a headache to the concept of migraine as a disease. Like now we know that there are 5 distinct phases. One is the pre-prodromal phase, then there is the aura, then there is the ictal phase, then there is a distinct post-dromal phase, and there is a definite inter-ictal phase. So the migraine, we have gradually known that there are certain 5 stages in the migraine, and each distinct stage has got its anatomical as well as the pathophysiological mechanisms for its development. As we know that migraine may be lifelong, but it varies in the impact, severity, and frequency throughout the life. The burden of migraine extends beyond the individual attacks, with 1 in 4 migraine patients experiencing interictal symptoms, maybe more. And we know that migraine is not just a disease, not just a headache. So migraine affects almost over 1 billion people globally and is responsible for approximately 41.1 million years lived with disability. This is one disability adjusted life year charting, in which we know that there is a huge global burden for migraine, and in the East Asian population and in the Southeast Asian population, the burden is much more. There are many studies which have looked into the prevalence of migraine in India, and there are studies from South India, in the part of the northern India, and from the eastern India also. The actual prevalence ranges in the range of almost 25%. However, some of the studies, like from our eastern India, it says that it can be less towards the prevalence of 14%. We know that we have already discussed about all these diagnoses of migraine. We will gradually move. Now, regarding the management of the migraine, we know that there are 2 types of migraine management. One is the acute treatment and another is the preventive treatment. So for many years, we have relied on this preventive treatment mainly on the borrowed medications, I would say. Like some of the medications we have borrowed from the epilepsy basket, some of the medications we have borrowed from the hypertension basket, some of the medications we have borrowed from the psychiatry basket. But now we have got certain specific molecules which are being targeted, like the CGRP, the PACAP molecules, the orexinergic pathway, and so we have got a plethora of treatment options which are coming up now, which have targeted the actual pathobiology of migraine. What is the standard recommendation? Like in case of the acute migraines, the acute attacks, usually the dictum is to start with simple analgesics, the NSAIDs, and the antiemetics when it is necessary. If there is some, also try initially with the triptans, but if usually the over-the-counter medications or the analgesics fail, then we shift to the triptans. And then we can combine the triptans with the analgesics also. Now, if the triptans fails, now you have to define how the triptans are failing. There may be 2 scenarios. Like some of the triptans, they may be ineffective to abort all the attacks. There might be adverse effects with the triptans, and some might be partially effective. Like in some of the migraine attacks, they may be effective, but in some of the migraine attacks, the same triptan may not be effective. So we can switch between the triptans, but if again it fails, then we have got the newer options like the Gepants, the Gepants. Now, regarding the CGRP molecules, we know that it is a polypeptide, and what happens in the migraine pathophysiology is that from the peripheral sensory nerve fibers which travel towards the dura, and then they come back and then they go to the hypothalamus, then they go to the thalamus and several other structures, and there is release of CGRP from the trigeminal nerve endings. and then they act on the smooth muscles on the vessel walls, and there is activation of the cyclic AMP pathway, and there is some vasodilatation, which can trigger the migraine pain. However, it has been shown that during the prodromal phase only, there is activation of the hypothalamus itself. And there are certain features which develop in the prodromal phase, like the yawning, like excess food craving, like some patients develop the mood alterations, and they come in the prodromal phase itself. And then there comes the aura phase, and then the ictal phase. And even in the postdromal phase, which lasts almost say about 24 hours or so, and then the interictal phase. Even some of the patients can develop the cognitive impairment, mood changes during the postdromal phase also, and there are also involvement of some other pathways, like the hormonal pathways, like the glucagon pathways, some leptin pathways, etc., which can also lead to some of the complications in the interictal phase itself. So we had the triptans which were mainly targeting the 5-HT1B and 1B receptors, and had had the benefit that it would stop the release of the CGRP from the sensory nerve terminals. And then we got the lasmiditan, the detans that do not affect the 5-HT1B or the 1D pathway, the receptors, but they mainly act on the 5-HT1F. So they had the advantage, like the triptans, they had many disadvantages, like they had led to vasoconstriction, and so the effect was like in the cardiac system, the central nervous system, leading to the strokes, and also there were some concerns with developing some of the peripheral vascular diseases, but they were not present with the detans. So the detans were lacking that vasoconstrictive effects, and that's why we have the advantages with the detans. And then we have the other CGRP targeted therapies, like now we have got the erenumab and also the Gepants. There is also other agents like the Botox, the onabotulinum toxin A, etc. The main problem with use of the triptans had been that there is a significant risk of developing medication overuse. Like some patients tend to take the triptans and they tend to overuse the triptans, and they have got higher chance of developing the medication overuse headache. Now there are other factors, like there can be some scenarios in which the patient we have not used the triptan in the adequate dosage, in the appropriate timing. Like when some of the patients they wait for the pain to develop, they wait for the time that the headache bout will be severe, and then they will take the rescue medicines or the triptan when they have been prescribed. But it has been shown that if we wait for a sufficient long period of time and the patient is not taking the triptan in the beginning of the headache, then there is a fair chance that the headache bout will not subside with the triptan. And then the patients develop cutaneous allodynia, which is a marker which has been shown to be a marker that this headache bout will not subside, and this headache can recur within a 24 hours time, and then the patient has to take a second triptan dose, and maybe if they fail with the second triptan also, they have got a tendency to take some rescue medicines or again another triptan, which adds to the risk of the medication overuse headache. Also, there is a common tendency that we as clinicians or neurologists in migraine, we tend to look towards the headache bout itself. But nowadays, we are shifting from the headache-oriented view to the other view, which targets also the migraine-associated most bothersome symptoms. Like there are many retrospective studies which have shown that, especially there was a large study in the US which looked into the most bothersome symptom in case of migraine. And it has been shown that usually the male persons who have got visual aura, they also develop photophobia, and they have got the photophobia as the most bothersome symptom. Like in case of the women who have previously had got the nausea as the most bothersome symptoms, they are usually obese, and they usually have failed the triptans. So there are certain some migraine most bothersome symptoms which have been looked into, as far the retrospective studies are concerned. So what are the guidelines at present? Like we have to look towards whether the patient is a triptan responder or whether the patient is a triptan failure patient or whether the patient is a triptan ineligible patient. Like some of the patients who have got contraindications to triptan, like they have got some peripheral arterial disease, say they have got some coronary arterial disease which is active, and they have severe renal or hepatic insufficiency, they can be triptan ineligible. And then there can be the scenarios like triptan failure, when the triptan responder may not meet the who have met the initially the criteria for the triptan responder, but then they have gradually become failed with the as the time has progressed. So they have failed one triptan, and then they have been classified as non-responder. If they have been failed 2 triptans, then they can be triptan resistant. And if they have failed 3 triptans, then they can be classified as triptan refractory. So the mismanagement of migraine can significantly impact the quality of life and can lead to medication overuse headache. And it can lead to headache chronification. So we have to keep it in mind and prevent the chronic migraines. So we have to prevent the disease progression from the episodic migraine to development of chronic migraine and then to medication overuse headache. So that is our target. So what is the role of CGRP in the migraine management? We have known that CGRP can be elevated in the acute phase as well as in the interictal phase also in the chronic migraines. And studies have shown that the plasma levels are elevated during and outside the migraine attacks in people with migraine. And we already have discussed all those things, like the CGRP dilates the dural arteries and it triggers a neurogenic inflammation leading to hyperexcitable nerve signaling and exaggerated pain signaling from the brainstem. The CGRP and CGRP receptor antagonists disrupt this migraine pathophysiology at multiple sites of action. Like now we have got, apart from the CGRP receptor antibodies or the CGRP ligand antagonists like the erenumab or the other maps, we have got the Gepants, and there are 4 Gepants which are nowadays available. Like one is ubrogepant, one is rimegepant, another is atogepant, and the rimegepant. Among these Gepants, the ubrogepant, it has been used as the for the treatment of the acute migraine attacks. The atogepant, it has been used for mainly the chronic migraine part, and the rimegepant, it has been approved for both the acute migraine as well as for the prophylactic therapy. Regarding the zavegepant, it is an intranasal formulation, and it has been mainly approved for the acute migraine prevention. Now, the rimegepant has been investigated in a broad clinical development program, including the acute treatment and the prevention of episodic migraine in adults. Like it has been in the initial phase 1 trials, it has been seen that whether it has got how the doses, how it behaves with the doses, like the highest of the doses has been tried, and it has been compared and it has been studied with whether its co-administration with the sumatriptan is effective or not, and whether there are any adverse effects or not. And then there are the phase 3 studies, and which have evaluated the efficacy, the safety, and tolerability of the rimegepant. And the plain formulations have been tried, and as well as the orally disintegrating tablets were tried. In the pooled phase 3 trials, from 3 trials in the treatment of acute management of migraine, there was a screening phase for 3 to 28 days, and then there was a phase of randomization. In this randomization phase, the rimegepant was given as a single dose of 75 milligram oral formulation, and then there was an end of study visit within 7 days after the study medication. There were some parameters which were looked into, like the migraine pain freedom at 2 hours and whether the most bothersome symptoms at the 2 hours period were free, the patients were free from those most bothersome symptoms. And the end of study visit, at 7 days, these parameters were studied. And if we look carefully into the inclusion and the exclusion criteria, especially the exclusion criteria, we would see that these studies have categorically excluded some of the patients like the uncontrolled, unstable, or recently diagnosed cardiovascular disease, the myocardial infarction, acute coronary syndrome, cardiac surgery, stroke, TIA during the 6 months prior to the screening. Now we have to keep it in mind that Gepants are not a new molecule. There were some Gepants which were introduced previously, and then these Gepants, due to their lack of tolerability, especially because of the adverse effects like the hepatotoxicity, they were withdrawn from the market. And then now we have got the second generation of Gepants like the newer Gepants. But here also in the actual study, that is the initial for the acute treatment pool data, they have categorically excluded this chunk of patients. And also they have excluded the uncontrolled hypertension, the diabetes, uncontrolled diabetes, all these patients in this initial part. And the patients who are pregnant or breastfeeding. Then the baseline patient characteristics, like some patients have failed one triptan, some patients have failed 2 triptans, and they were also included in this study. And there are many triptans which the patients have tried and they have failed, and then also they were included into the study. And then a reported history of discontinuation of any medication in the triptan class of all those triptan classes, as well as the combination of triptan and NSAIDs were taken into account. And the reasons for historical triptan insufficient response were taken, like whether the triptan took too long to relieve the headache pain, it could not count on the treatment to relieve pain or symptoms every time, the pain returned after it was released within 24 hours, like within 24 hours the pain returned, they did not relieve the other most bothersome symptoms. The treatment caused side effects for which the patient discontinued, so they were taken into account. Then in this slide they have categorized it into the triptan discontinuation, why the patients have discontinued the triptan. And if we look into the post hoc analysis of the pooled data in the pain and the migraine most bothersome symptom freedom in 2 hours of the post dose of rimegepant versus placebo, we can see that the pooled population data, it shows that the regardless of the patients whether they had used 1 triptan or 2 triptan, whether they had failed 1 or 2 triptans, the efficacy of the rimegepant was nearly the same as compared to the placebo. But the limitations in the study was that it was a single attack design. So these initial trials, they prevented the analysis of consistency of rimegepant treatment across the attacks. Like the patients can have rimegepant responsiveness in 1 attack, but they may not respond in the 2nd attack or the 3rd attack. So this was lacking in the study. Another limitation is that it was a post hoc analysis, and also as the individual rimegepant trials included in this analysis did not include any active comparator, like it was compared with the retrospective data, it was compared with the placebo, so it did not have an active comparator apart from the placebo. So the results of this analysis cannot be used to make a direct efficacy comparison of rimegepant with triptans or other treatments. So in conclusion, oral rimegepant 75 mg, it was effective for the acute treatment of migraine among participants with a history of triptan insufficient response. The efficacy of rimegepant was consistent among those with insufficient response to 1 or 2 triptans, and in the clinical implications were that rimegepant was effective in the acute treatment of migraine in participants who had insufficient response to 1 or 2 triptans. There were no clinically meaningful differences in the co-primary endpoints between the subgroups of the rimegepant treated participants. Then we came to the long-term safety study of rimegepant in the acute treatment of migraine, and then there was also a screening phase, and an observation phase of 30 days, and then there was a treatment phase which continued up to 52 weeks. And in this phase, the rimegepant as per needed doses were given to the patients, and there was a subgroup in which the patients were already on the CGRP MABUs, like they were on the erenumab or other kind of MABs. So they had undergone a short treatment phase in this rimegepant study, and it was for a period of 12 weeks. And at the end of the study, the adverse events, the serious adverse events and the laboratory abnormalities were looked into. Like the initial Gepants, they were discontinued mainly because of the hepatotoxicity. So in this study, the main focus was whether the hepatic functions or the hepatotoxicity was more in the patients, and whether that was leading to the discontinuation of the rimegepant treatment. So that was looked into. So in this cohort, there were three groups. Like one group was the 2 to 8 moderate to severe migraine attacks per month, and then there were 9 to 14 moderate to severe migraine attacks per month, this group. And in the 2 to 8 group, there was a subgroup who were using the CGRP MAB therapies. So that group was followed up for a period of 12 weeks. And in this group also, the key exclusion criteria, if we look towards the key exclusion criteria, the history of basilar or hemiplegic migraine, they were excluded. Like they have a, because of the fear probably that in case of the triptans, we have, if we use them in the hemiplegic migraine or the basilar, there is a common concept that it can lead to vasoconstriction and it can lead to some vascular side effects. So possibly keeping that in mind, these patients were also excluded in this long-term safety assessment. And some uncontrolled, unstable, recently diagnosed cardiovascular disease, ischemic heart disease, coronary artery vasospasm, cerebral ischemia, those patients were also excluded in this study. The uncontrolled hypertension, uncontrolled diabetes, they were excluded. Some history of GI or small intestinal surgery patients, they were also excluded in this study. And then they looked into whether there was some prophylactic migraine medications which will be permitted in these patients. Like the most commonly used preventive medications were topiramate, amitriptyline, Botox, but they allowed these kind of medications. But the criteria was that the dose must to be stable in the last 2 months prior to the treatment initiation, that is the baseline visit, and not expected to change throughout the study. Except for a few subgroup of population, the anti-CGRP MABs were not permitted in this long-term safety study. The previously prescribed standard of care medications or the rescue medications, they were also permitted, but the triptans were not permitted, except for the observation period. So then there were the primary objectives, the secondary objectives, and then there were some exploratory efficacy also that were assessed. Let us not go into the details of all these slides because of the lack of time. But as for the safety profile, the serious adverse events were really less. The most bothersome side effects that were encountered were really related to nausea, and they were present in very minimal of the patients, like the less serious side effects. The serious side effects were also very less. There was no signal of hepatotoxicity with the long-term and high-frequency rimegepant dosing. Like in rimegepant, we have known that it can be used in the treatment for acute migraine as well as it can be used in the treatment of prophylactic, like in case of the episodic migraine prophylaxis. But there is also some restriction of its use, like we cannot use the rimegepant like more than 18 tablets per month, and only 175 milligram of rimegepant is permitted throughout the day. So the rimegepant was well tolerated with concomitant preventive non-targeted migraine medications also. Safety profile by triptan failure history at 1 year of rimegepant treatment. Of the 1800 rimegepant treated patients, almost 44% had a history of treatment failure with more than one triptan, which is very important. Like, so we have known nowadays that if the patient had failed triptans, we can use the rimegepant. And the oral sumatriptan and rizatriptan were the most commonly failed triptans in both triptan failure subgroups. The frequency of adverse events were similar across the triptan failure subgroups. Most adverse events were mild to moderate in intensity in both the subgroups and deemed by the investigator to be unrelated to rimegepant. No serious adverse effects or deaths were reported. So, as per the laboratory abnormalities were concerned, the elevation of the ALT, AST or total bilirubin, which were taken into the criteria for the safety, they were not much elevated, and no participants in the treatment group had ALT or AST elevation of more than 3 times the upper level of normal. And the total bilirubin elevation was less than 2 times the upper level of normal in this safety study. And it was deemed that as per the cardiovascular safety is concerned, rimegepant was shown to be safe and well tolerated in adults with severe risk factors. Regarding the satisfaction with rimegepant and preference over previous migraine medications, it was seen that participants were satisfied with rimegepant throughout the phase, like at 12 weeks and 52 weeks, and most participants preferred the rimegepant over the previous migraine medications. So in summary, the triptans are effective for many, but some people need alternative treatments due to the poor response or tolerability of or contraindications of triptans. 20% of patients experience pain freedom with within 2 hours of taking rimegepant, and 36% of patients experiencing freedom from most bothersome symptoms. And 70% of patients experience pain relief within 2 hours after 2 triptan failures. The safety and tolerability of rimegepant in the long-term open-label study up to 52 weeks was consistent with the previous studies. Rimegepant offers rapid onset of symptom relief, sustained benefits over 24 to 48 hours, along with improvement in the most bothersome symptom, return to function, in addition to favorable safety profile. So, where we are now standing in this rimegepant molecule use, like we can use it maybe in the medication overuse area. Maybe that is one part that we need to see, that if the cost burden is not a fact, then maybe in case of the medication overuse area, it will be a good choice and a good option. And of course, in the triptan failures, if we have really and correctly defined the triptan failures.
Thank you, sir. Thank you for your way out in the management of migraine. So let me invite Professor Devashi Chaudhary, sir, to felicitate Dr. Anirban Ghoshal.
Just one point. See, at the moment, remember this, the only indication the DCGI has given for use of rimegepant is for treatment failure cases, triptan failure cases, right? So, for the suspected even MOH, that is not actually indicated, but that is one of the indications, one of the benefits that you can use the drug. Subsequently, I think the indications will broaden and will include all the patients with acute alternative migraine treatment. But at the moment, it is a triptan failure. Or if you are stuck with, say, other drugs, but the patient has contraindications to triptans, then you cannot use. So then there is a reasonable chance, although it is not spelled out, right, in the DCGI guideline. And secondly, each tablet is going to cost you 1,500 rupees per dose. So you need to select out your patients well, because otherwise it might be just that you would burden the and as I showed you that efficacy-wise, triptans are faring better than the rimegepant. Though in real world it is almost coming almost same to that, but there is a chance that it might or might not work. So therefore, I think initially you should be slightly cautious and you should use in a proper patient who can afford and who don't mind, popping up 5, 10 acute medications for rimegepant in a month. So something like that.
Sir, rimegepant is now not officially recommended in preventive therapy of migraine yet.
No, it is recommended.
In India.
India, no.
India it is not.
It is not. So no question of preventive this thing. But eventually, once the usage starts and the safety profile is established, because they are going to do a phase 4 assessment also, the safety is further, then they obviously they'll apply for that, and that will come. So that will come, but it will take some time. So till that time, you have to be slightly careful in using, because nowadays, you know, the other side is also there. The patient is spending $1,500 and then lands up with some problem or other, he can go to the court and see you if that is not indicated. So you have to be careful in this kind of